Okay. So thank you, Shanawaz bhai. So we can start the session now. And today we will take PYQs of anesthesia from NEET-PG exam. So the very first question was like for a lady with severe preeclampsia. Varun, good evening. In fact, it is good night. Anyway, so for a lady with severe preeclampsia, what kind of anesthesia would you prefer if you are planning for cesarean section? So now here the lady is already hypertensive. Okay, so severe preeclampsia means there is hypertension, and in such cases, if we are going for cesarean section, the best is spinal anesthesia, right? So because in normal people with spinal anesthesia there is possibility of hypertension, but in cases of these pregnancy induced hypertension or preeclampsia patient, that tendency is very less, and therefore we prefer spinal anesthesia in a lady who is planned for cesarean section and is having preeclampsia, right? So the answer is spinal anesthesia. Now why I have preferred this question, because I just want to discuss something about spinal anesthesia with all of you, right? So now here many times we have seen like there are questions like which ask you like what are the structures which are pierced while doing spinal anesthesia, right? So depending on that midline approach, right, so that this is the question which is very frequently asked. Like they will give you 4 options and then they will ask you like which of the following structure is not pierced, right? So for that, of course the outermost structure is skin, right? So the outermost structure is skin. Then deep to skin will be subcutaneous tissue. Okay, so here will be subcutaneous tissue, and now after this there will be some ligaments, right? So now here you have to understand that if suppose these are the spinous process of the, okay, let me draw it a little bit nicely. So suppose these are the spinous processes, something like this. Okay, so firstly you will have a ligament which is something like this. So this is the supraspinous ligament, right? Then deep to this you have the interspinous ligament, right? So this is interspinous ligament, right? If you come even more anteriorly, you will have ligamentum flavum, right? So here there is ligamentum flavum. Clear? So these are the 3 ligamentous structure which the needle has to pierce, and going from outward to inward, the most outward ligament is the supraspinous, then deep to that is interspinous, and the most deeper in terms of ligament is the ligamentum flavum, right? So this you have to remember, this sequence you have to remember, and you can remember it like flavum, interspinous and supraspinous, right? So you can just make your own mnemonic, it's all up to you, right? So skin, subcutaneous tissue, and we are going in this manner, right? So skin, subcutaneous tissue, then we have the supraspinous ligament, right? So this is supraspinous. Deep to supraspinous is interspinous, so this is interspinous, right? And deep to interspinous is ligamentum flavum. Okay, so this is the ligamentum flavum, right? So after piercing all these structures, now finally we'll reach to the meninges part, right? So right, deep to this we will have the meninges part, and of course the outermost meninges would be the dura mater, right? So this is the dura mater. Deep to dura mater we will have the arachnoid mater. Okay, so this is the arachnoid mater, right? And the needle has to pierce the arachnoid mater so as to reach into the subarachnoid space, right? So here this is the subarachnoid space where we have to inject the local anesthetic. So this is the subarachnoid space. Clear? So the needle has to pass all the way from here and it should reach up to here. Clear? So this is the order of piercing of the structures whenever we are giving spinal anesthesia. Clear? So just to revise the structures again, the outermost skin followed by subcutaneous tissue, then 3 ligaments, supraspinous, interspinous and ligamentum flavum, and then we will come to the meninges, the dura mater, and finally arachnoid mater, right? So we will reach up to the arachnoid space. Now Shanwas mentioned epidural space. So when we say epidural, it is that we have to limit ourselves above the dura mater. So for epidural, the needle will reach somewhere here only, right? So this is epidural. Clear? So the needle is just reaching just above the dura mater. It is not piercing the dura mater. And when the needle is piercing the arachnoid and going into the subarachnoid space, this is the spinal anesthesia. So I think the difference between the spinal anesthesia and epidural anesthesia would be clear to all of you. So in cases of epidural, we have to inject the drug in the space above the dura mater, and whereas in case of spinal we have to inject the drug below arachnoid mater, that is the subarachnoid space, which actually contains the CSF. So here we have all CSF, right? So this is one thing between the difference between the spinal anesthesia and the epidural anesthesia. Now in other terms, like what is the difference, like if we take few differences between spinal anesthesia and epidural anesthesia. One is of course the placement of the needle. So another is like if you say epidural, right? So in spinal anesthesia, the drug is injected into the subarachnoid space which contains CSF, whereas in epidural it is in epidural space, right? This is one difference. Then second is, now the why epidural is more advantageous otherwise, not in relation to this particular MCQ, otherwise, because in spinal anesthesia we just inject a fixed dose of the anesthetic agent. Whatever the dose we have to give it once. But with epidural anesthesia, we can prolong the duration of anesthesia, right? Because there is an epidural catheter and we can inject some more amount of anesthetic agent if needed, right? So that is not the liberty with spinal anesthesia. And suppose whatever the drug has been given, the effect will be for certain period, and if the surgery has not been done within that time period, you have to supplement with general anesthesia, right? Especially in cases of orthopedics, when the surgery takes a lot more time than expected, then and once the effect of the spinal anesthetic goes down, we have to give additional GA to continue the surgical process. But in cases of epidural, we can simply inject the agent through the epidural catheter, and there is no need of giving supplemental GA because we can prolong the duration of anesthesia by the epidural route. So epidural route give us this advantage that we can prolong the duration of surgery by giving the anesthetic agent through the catheter. Okay, so there is a catheter in the epidural space. Now, the another important difference is that no post-operative analgesia through this spinal anesthesia thing. But what happens, like if we are giving epidural, if we are just putting the epidural catheter, we can give post-operative analgesic agents, right? So we can just inject the the analgesic agent through that catheter. So we can control the post-operative pain. So we can give post-operative analgesic drugs. So these are two main advantage of epidural over spinal. We can control the duration of surgery, and we can give analgesic agent as well. Now, what is the disadvantage? In terms of disadvantage, now this is a simple technique, right? Many people can do it very easily, but this is a expertise. It is an expert technique, so a person has to be quite perfect in performing epidural anesthesia, because you have to restrict yourself above the dura mater. So that needs a lot of practice, right? So this is the dura mater, right? So this is dura. Clear? So just a basic difference between the structures which are pierced in spinal anesthesia and epidural anesthesia, and overall few basic differences between spinal anesthesia and epidural anesthesia. Now, in cases of spinal anesthesia, the level of spinal anesthesia, again this question is asked very frequently. What is the level where you will give spinal anesthesia? Now here, I think most of you must be knowing it. It is, in some books it is L3, L4, somewhere you can find L2, L3, like that, right? Now, what is the concept behind it? The concept is that spinal cord ends at L1, L2 in adults, right? So this is in adults. So what we do, we have to give the anesthetic agent, we have to inject the anesthetic agent below the level of termination of spinal cord, because what we do, the target, we are not targeting the spinal cord, we are actually targeting the chorda equina, right? So our target is to block the chorda equina. Therefore we prefer to inject the drug below the level of termination of spinal cord, and therefore either it is L2, L3 or L3, L4. So that is the basic concept, right? And chorda equina are actually all those nerve roots. Like chorda, the word chorda is tail, right? And equina is actually horse. So all those nerve roots, if you can just see the anatomy, like suppose if this is the terminal point of spinal cord, this is known as conus medullaris, right? And then all the nerve roots, they emerge, they are placed something like this, right? And since they appear like a tail of a horse, so this is known as chorda equina. So this is our target area while giving spinal anesthesia. We aim to block these nerve fibers of chorda equina. That's why we always go low. That's why we always go below the termination of spinal cord, right? So this is in short about the concept of spinal anesthesia and epidural anesthesia. And again, you can see here in this image, this is say dura mater. Okay, so suppose if this is say the dura mater, and deeper to this is arachnoid matter. Okay, so this is the arachnoid matter. And this is all CSF in subarachnoid space, right? So we have to inject the drug here only in the subarachnoid space, and therefore we have to pierce the arachnoid matter, right? And of course these are the nerve roots of chorda equina. Clear? So this is the concept of spinal anesthesia. And yes, of course, if we inject the drug here, this is the epidural anesthesia. So this becomes epidural, because we are not puncturing the dura mater, we are just depositing the drug before or above dura mater. So that becomes, this is all epidural, right? So this is all epidural. Clear? So this is epidural anesthesia. And of course, if we are injecting the drug into the subarachnoid space, this is all spinal anesthesia, right? So this is the spinal anesthesia. Clear? So I think this much is sufficient in terms of spinal anesthesia. Now moving forward to the next question. Here a child was being operated for some eye surgery, and then there was a sudden reduction in heart rate from 140 to 40. Now what will be the next step here? So there is an eye surgery going on, and then heart rate was 140, which dropped to 40, right? So what should be done immediately? Yes, any idea? Yes, look at the option, what you can do here. Yes, anyone? What can be done here? Okay, let me help you out. So if there is some surgery going on, this is, you can put the word oculo here, right? And this is related to the word cardiac. So actually this phenomena is known as oculocardiac reflex, right? So this is known as oculocardiac reflex. Whenever we are operating on the eye, and if there is some pressure over the eyeball, or if there is some pressure over the extraocular muscles, there tends to be a reflex fall in the heart rate, right? And therefore what you need to do, just stop for some time, because this is actually a reflex process. So if you stop the surgery for some time, it will recover, the patient will recover, right? So we need not do any intervention as such. It's just stop for some time and let this reflex abolished by itself, right? So this is oculocardiac reflex, where if we are operating on a person, and if there is any pressure over the eyeball, that results in dropping of the heart rate, and this is because of activity of parasympathetic, or what you say, vagal, right? So involvement of vagus or parasympathetic activity. So this is oculocardiac reflex, and you need not do any intervention, just wait and watch. So whenever there is pressure over the eyeball or extraocular muscles, especially medial rectus, then the sensations are, the the efferent is actually the fifth nerve, right? So the efferent is the fifth nerve, and the efferent is the 10th nerve, right? So the efferent, the efferent is fifth nerve and the efferent is 10th nerve, and through the involvement of the parasympathetic system, there will be bradycardia, right? So what you need to do, just wait for some time, hold the surgery for some time, and this will abolish the reflex. The heart rate will come back to normal automatically, right? So this is oculocardiac reflex, and because of the efferent is fifth nerve and the efferent is 10th nerve, right? So if we just write efferent is cranial nerve 5 and the efferent is cranial nerve 10, right? So this is oculocardiac reflex, and this question has been repeated in FMG also. Okay, chalo, next question, and this question I think all of you must be knowing, and it has been repeated in almost every exam every year, right? So Mallampati grading or Mallampati score. So I think most of you must be able to answer this particular question about Mallampati grading. Very good, Shanwaz, very good. So to rule out difficult intubation, right? So what we do, we actually assess the oral cavity, and we get an idea like whether we are going to face any difficulty while intubation or we can do it simply. Yes, just a song, you are absolutely right. This is to rule out difficult intubation. Now just have a little, we will have a little word about what actually we do in Mallampati grading. So for that, you need to understand the normal anatomy of the oral cavity first, and what actually we look here to grade this Mallampati grading, right? So firstly, what you will see, the bony palate is known as hard palate, right? So this is hard palate, clear? This is the bony part of the palate. Deep to the hard palate, or you can say inner to the hard palate, is the soft palate, right? So this is the soft palate, and we call it soft palate because that is made up of muscles. So this is the soft palate. Then from the palate you can see one structure which is hanging down, and it looks like the alphabet U, so it is uvula, clear? So this is uvula. Okay, so these are three structures. Then we will go towards little deeper, and we will see two fascial pillars, right? So this is the anterior fascial pillar and this is the posterior fascial pillar. Okay, so like this is the anterior fascial pillar, and deep to this will be the posterior, this is the posterior fascial pillar, right? And in between the two you can see the tonsils. So this is the tonsil, right? So you will see the tonsil something like this, clear? So these are the structures which we will assess during Mallampati grading, and even more deeply you can see the posterior pharyngeal wall, right? So the deepermost structure is the posterior pharyngeal wall. Now when we grade, when we do the Mallampati grading, we have to see how many structures we can visualize. We tell the patient to open the mouth and we want to see how many structures we can visualize. So in class 1 we will see all the structures, right? So in class 1 we will see all the structures. So if I write here class 1, all structures visible, and therefore it means the patient is able to open the mouth easily and fully, and therefore intubation will be very easy. We won't find any difficulty in performing intubation. Now in class 2, we will see that the mouth is not fully opened, and what will happen, we will be seeing only half the portion of the fascial pillars, right? So what we will see, we will see that only the upper part of the fascial pillars is clearly visible, right? So this is anterior and this is posterior. This is anterior, this is posterior, right? So the lower half is all covered by the base of tongue, right? So in class 2, upper part of fascial pillar is visible, right? Only the upper part of the fascial pillar is visible, and at times we can see that uvula also is not fully visible, right? So at times we can see only the half part of uvula. So upper part of fascial pillar and upper part of uvula is visible. Clear? So in class 1 we can see the entire length of the fascial pillars and entire length of the uvula, but in class 2 we can see only half of the upper part of fascial pillars and uvula, right? Now in class 3 we will not see any portion of fascial pillars and uvula. So in class 3, fascial pillars and uvula is not visible. Clear? And now here you can just take one more word here for better understanding. Now this hanging part is the uvula, and this is known as the base of uvula. Okay, so if we draw uvula something like this, so this is the base of uvula, which is in relation to the soft palate. So in class 3 we will not see the fascial pillars, we will not see any part of the hanging portion of the uvula, but what we will see only the base of uvula plus hard palate and soft palate, right? Hard palate, soft palate will be seen everywhere, right? So we can just add here, right? And even you can say base of uvula, right? Clear? So this is stage 3. We will see only the palate, hard palate, soft palate, and the base of uvula. Now what we will see in stage 4 or the class 4, we will not see even the base of palate and we will not see even the soft palate. What we will see? We will only see the hard part of the palate, that is hard palate. So in class 4 we will see only hard palate. Clear? So it means the mouth opening is so less, we can only see the hard palate, right? So this is Mallampati grading, and it gives us an idea that if we are going for intubation, whether we will do it easily if the patient can fully open the mouth, or if the mouth opening is not adequate, what difficulty we are going to face depending on the degree of opening of mouth, right? So this is Mallampati grading, and out of all these, class 1 is, like we can say, easy intubation, and class 4 is difficult intubation because mouth opening is very less. Now previously exam setters, they used to just simply give you Mallampati grading is done for what. Now they are just putting into an image based question, and they will show you one particular thing, and then they will ask you this is what class of Mallampati grading, right? So you have to remember the entire grade properly. So in class 4 you will see only hard palate, and we can just write in a better way, right? So if we write the class here, right? Okay, or we'll take some more space. So suppose if we write the class here and then structures visualized. Clear? So I'll start from class 4 because then it will be very easy for me to correlate the things or to tell you the things. In class 4 we will see only hard palate, right? In class 3 we will see hard palate plus so we will see hard palate plus soft palate plus base of uvula. Clear? In class 2nd we will see all of these, right? So we will see hard palate, we will see soft palate, we will see base of uvula, plus we will see upper part of uvula, the hanging part, and we will see the upper part of the anterior and the posterior fascial pillars. Clear? And now in stage 1 what we will see? We will see everything, right? So it includes hard palate, soft palate, then base of uvula, uvula proper, and then anterior fascial pillar, posterior fascial pillar, right? So this is the order of the structures which will be visualized, and out of these 1 and 4 are quite easy to understand. In 1 you will see everything, in 4 you will see only hard palate, in 3rd you will not see any part of the fascial pillars or the hanging portion of uvula, right? And then in 2nd you will see half of the part of the hanging uvula or the fascial pillars, right? So please remember this, and this is again a very important segment. Definitely in one or other form you are going to have question from this, right? And this we have witnessed over the years. Now there is one question about Murphy's eye. Any idea where we find this Murphy's eye? Wonderful, Shanawaz, wonderful. Yes, we see it in endotracheal tube, right? So endo means inside, tracheal is of course trachea, right? So now let us see what this Murphy's eye is. Now this is the end of the endotracheal tube, and here you can see there is an opening, and this opening is known as the Murphy's eye. Okay, so this opening is known as the Murphy's eye. So this opening is known as the Murphy's eye, right? And what is the purpose of this Murphy's eye? Because see, this is the usual end, but sometimes it might get blocked. So this Murphy's eye makes sure that the ventilation continues and it does not step at the if the tube is blocked. So it makes sure that the ventilation process carries on. So it's just an alternate channel for ventilation. So this is Murphy's eye, right? So a part of endotracheal tube. So makes sure ventilation carries on even if the ETT is blocked, right? So if this beveled part is blocked, it makes sure that the ventilation continues. So this is Murphy's eye. Now some questions related to the anesthetic agents, and one is about the choice of induction in a patient with cardiac tamponade. Right, so what drug we will prefer in a patient who is having cardiac tamponade? See, in cardiac tamponade, I think if you remember, there is one backstride, right? So there is one backstride, right? And in backstride, we have three components. Obviously, the very first is hypotension, then raised JVP, and then muffled heart sounds, right? So I am more interested in picking up this word, hypotension. Jalaj here, Jalaj, absolutely you are right. So I am more interested in discussing hypotension part, because if you have, if you know the properties of ketamine, it increases all pressures like BP and other things, right? So therefore, if there is hypotension, we can or we should prefer ketamine, right? So the better answer to this, in case of cardiac tamponade, we will go for ketamine, right? Because it increases the heart rate by increasing myocardial contractility or peripheral vascular resistance. So heart rate will increase, so BP will also improve. So this is very important in this particular case, that is cardiac tamponade. So ketamine is a better answer if anesthetic agent is asked for cardiac tamponade, right? So please remember ketamine. Chalo. Now, anesthetic agent which causes maximum respiratory depression. Now these are some questions, there is no much logic and you have to just memorize. So maximum respiratory depression, this is, yes, anyone would like to make a guess here? Maximum respiratory depression. Okay, for this I think it's better you remember N-fluorine, right? So there is a sequence also, like N-fluorine followed by desflurane followed by isoflurane, then sevoflurane, right? So that is the sequence here. So please remember N-fluorine for maximum respiratory depression, right? So just remember N-fluorine. Okay. Chalo. Then next question. Maximum pain on IV injection. Maximum pain on IV injection. Shubham, Sikdar. See, yes, it is being said that most of the IV anesthetic agents, they cause pain, but if you take the example for the agent which causes maximum pain, the answer has to be etomidate, right? So this causes maximum pain out of all the IV injectable agents. And apart from this, there is one important side effect, that it depresses adrenocortical axis. So depresses adrenocortical axis, right? So this is very important here. So just remember, it depresses adrenocortical axis. So just two things. It pain on IV injection is that is the maximum possibility, and then it adrenocortical suppression, right? So this is very important here. And even like for this, the time duration has been given as nearly, the axis remains suppressed for 4 to 8 hours. And since you know that it is going to suppress adrenocortical axis, so never give etomidate in a patient who is already having adenocortical suppression, right, or insufficiency. So don't give, especially like Addison disease, so don't give this particular IV anesthetic agent to a case with Addison disease who is already facing insufficiency of the adenocortical axis, because this will just aggravate the condition, right? So there are just two important points which I want to share regarding etomidate: maximum pain on IV injection and suppression of adenocortical axis, although it just resolves by around 8 hours, right? So please remember etomidate. Now the next question is about the IV anesthetic agent which is not a cardiodepressant. So IV anesthetic agent which is not a cardiodepressant. Yes, anyone? Any idea which of the following is not a Shubham? Yes, your guess is correct to an extent, but if you take all the agents, then the best answer would be etomidate, right? So the best answer would be etomidate. And yes, for sympathetic, we for this ketamine, we just discussed that it increases blood pressure, right? So in that sense, Shubham, you are right, but etomidate has no action on cardiovascular, no depressive action on cardiovascular physiology whatsoever. So better is always etomidate. Okay, so it has minimal cardiovascular depression effect. So please remember that, right? And yes, ketamine you can think of, but if both the options are given, it's better you go for etomidate, right, Shubham? So etomidate is better answer here. Chalo. Then another question is about Cisatracurium, and this is preferred over atracurium. And I think the moment you hear the word atracurium, you all think might be thinking of that Hoffman elimination, right? So now here, instead of atracurium, we prefer giving Cisatracurium. Now actually there are two important reasons for that. And of course, one is in this question, second I'll tell you later. So any idea why you will prefer giving Cisatracurium instead of atracurium? Very good, very good. So one reason is that Cisatracurium does not cause histamine release. Now this atracurium, it releases histamine. And what are the effects of histamine? Of course, there will be flushing, there can be hypotension, right? So if we are giving Cisatracurium, we are obviously avoiding these side effects like flushing or hypertension, which is because of histamine release. Number one. Number two, this is of course one. There is one metabolite of atracurium, and that is known as lodanosine, right? And this lodanosine has a tendency to cause seizures, right, or epileptic fits. Very good, Shubham, very good. That is lodanosine. And very good, Shubham, really appreciate that. So this metabolite is not produced here, and therefore the chances of these epileptic fits are minimized. So Cisatracurium does not release histamine, and it does not results in lodanosine, and therefore the chances of seizures are minimized. So that is two important reasons why we prefer Cisatracurium over atracurium. Number one, it releases less histamine, and number two, it releases less lodanosine, which is actually responsible for epileptic seizures, right? So these are two important differences between these two agents. And of course, I think most of you must be knowing that there is concept of Hoffman's elimination, where the drug are metabolized non-enzymatically, and there is no involvement of liver or kidney, and therefore it is safer to give these agents in hepatic or renal insufficiency. Clear? So these are few things which you should know about atracurium or cisatracurium, and most of the time the question revolves between these facts only. Clear? So just remember this much. So two advantages of using cisatracurium over atracurium: less histamine release and less lodanosine release. Right. Chalo. Now we will take end-tidal CO2 curve, and the curve is something like this. Now what you can expect or what you can say considering this end-tidal carbon dioxide curve or capnogram? Any idea? The additional thing which you can see in this curve is a dip here, right? So you can see a dip in the curve, because in a normal curve we don't have this dip. It just states something like this. So this is usually okay, and if this dip is there, what does it signifies? So if very good, Shubham, very good, very good. Yes, this is spontaneous breathing efforts. Very good here, right? So these are right. So efforts, it is efforts, right? So this is spontaneous breathing efforts. Now we can just take the opportunity to discuss a little bit about this EtCO2 also. And here you can see there are two phases, and this is actually checking the carbon dioxide levels, right? So obviously when the patient is inhaling, the carbon dioxide level will be 0, right? So this is actually carbon dioxide level, you can say. So whenever we are inhaling, obviously CO2 will be 0, because there is no exhalation at all. It is only during the process of expiration or exhalation the CO2 level will increase, right? So in phase initially there is slight phase 1, okay? So there is slight phase 1, and then is slight, and then in phase 2 there is the CO2 which is released from the pulmonary area, especially the the anatomical dead space and all. So this CO2 will keep on increasing, and in phase 3, when there is that carbon dioxide which is coming from alveoli, we will have this highest level, and it will show almost a plateau. So there is a plateau, something like this, and the maximum level is this, right? And after that, when the patient will, now at this point of the graph, the exhalation or the expiration will stop. After that, patient will inspire, and therefore the CO2 level will drop down to 0. Okay, so this is the end-tidal CO2, or which is known as capnography. And if you have a dip like this, it is just telling you that the patient is trying to breathe spontaneously. So that is spontaneous breathing effort. So just to give you a basic idea, phase 1, this is inspiratory, so obviously CO2 will be 0. In phase CO2, there is beginning of expiration, those CO2 will start coming, and this usually comes from the anatomical dead space followed by the alveolar gas, which is quite rich in CO2, right? So in phase 3 it is the alveolar plateau which is having the CO2 coming from the alveoli, and here we find the peak CO2, right? And in phase 4, again, as the patient starts taking breath, CO2 will become 0. So this is the end-tidal CO2 waveform or capnogram, what you say. So this all tells you about the amount of carbon dioxide which is exhaled, right? So if you normally the curve should be like this, but if you have a dip anywhere during the expiration phase, this is suggestive of spontaneous breathing effort. Okay, so this is one good question. Now another question from anesthetic agents. So which of the following increases cerebral blood flow and cerebral metabolic rate? Which of the following increases cerebral blood flow? So cerebral blood flow and cerebral metabolic rate. Yes, any idea? Cerebral blood flow is increased, cerebral metabolic rate is increased. Shubham, yes, you are absolutely right. So if we look here, now this is the cerebral blood flow. Okay, so if we look here, this is the cerebral blood flow, and nearly everyone is decreasing the cerebral blood flow. So propofol, we all know that propofol is cerebroprotective. So propofol is decreasing, barbiturates decreasing, etomidate decreasing, then benzodiazepines decreasing, opioids decreasing, dexmedetomidine decreasing. But there is only one name which is increasing the cerebral blood flow and the cerebral metabolic rate, right? So this is for ketamine. It increases cerebral blood flow and cerebral metabolic rate. Yes, very good, Avik Das. Yes, and that's the reason why we don't prefer it. Yes, so that's why it is contraindicated in patients with raised intracranial tension. So don't never use ketamine if somebody is having hemorrhage, abscess, or any space occupying lesion. Don't give ketamine in such cases, because the intracranial pressure is already raised and you would result in unnecessary trouble, right? Because it has a tendency to increase the intracranial pressure, right? So you can just write pressure also here. So this is intracranial pressure. Fine. So don't give ketamine in raised ICP cases. Very good, Avik Das. Good point. Chalo. So that's enough for this session, and I hope you must have enjoyed the session. So see you tomorrow with I think tomorrow I'll take radiology, right? So I'm just trying to finish off the minor subjects first, and tomorrow I'll take radiology, and yes, I'll try to come live at 10:30 p.m. Indian Standard Time. So thank to all of you for just sharing your valuable time with me so late at night. Thank you, Shanavas. Thank you, Avik, Shubham, Jalaj, and Rajat, everyone. Thank you so much. God bless.